2, 1, go.
Good evening, everyone, and thanks for joining. My name is Rishi Kartare, and on behalf of Hetero Healthcare family, I welcome you all to the webinar on post-COVID-19 complications, management options, current and newer perspectives. COVID-19 virus is evolving and mutating. Not only is it is affecting lungs, but is causing post-COVID complications. We at Hetero Healthcare have always been in forefront and along your side in this fight against the deadly virus. This evening, our esteemed and experienced doctors will share their practical experiences on the subject. And with further ado, let me introduce you to the moderator of the evening. And it's a privilege to introduce Dr. Shithesh Roy. Well, Dr. Shithesh Roy is a founder of Dr. Roy Health Solution Multi-Specialty Clinic, Bandra. He is a former medical director of esteemed Dr. Nifarkar's Asthma and Allergy Healthcare in Dadar as a senior consultant, allergist, immunologist, and asthma specialist. Prior to returning to his hometown in Mumbai in 2011, he was a senior consultant at Columbia Asthma and Allergy Clinic in Vancouver, Washington, where he managed 3 busy clinics seeing both children and adults with variety of allergic, immunology, and stress-induced disorders. Dr. Roy has also been an associate professor of pediatrics and medicine at University of MS Medical Center in Jackson, and where he has also served as a director of Jackson Medical Mal Allergy Immunology Clinic from 2002 to 2010. Dr. Roy received his Bachelor of Medicine and Bachelor of Surgery from Seth GS Medical College, University of Bombay in 1996. He completed a residency in pediatrics at University of Illinois Hospital, Chicago in 2000. He went to complete his fellowship in allergy and immunology at the National Jewish Medical Research and University of Colorado School of Medicine in Denver in 2002. Dr. Roy has authored a number of articles and publications from leading medical journals as well as book chapter titled Stress and Allergic Diseases for the Volume 2 textbook of Psychoneuroimmunology, 4th edition in 2006. Dr. Roy has been a diplomat of American Board of Allergy and Immunology, a co-joint board aggregated to American Board of Pediatrics and American Board of Internal Medicine. He is a fellow of American Academy of Pediatrics and American Academy of Allergy, Asthma and Immunology, and American College of Allergy, Asthma and Immunology. Dr. Roy was listed as the best doctor in America from 2005 to 2010 and again in 11 and 12, as well as in the Guide to America's Top Physician from 2005 to 2010. So I welcome Dr. Roy and invite him to take over the session. Over to you, Dr. Roy.
Thank you very much, Rishi. That's a bit extensive of a introduction, but I appreciate it. It's a great pleasure to be with the Hetero family again and with our co-panelists this evening on the topic of post-COVID complications. As you have rightly said, this is a significant and serious issue that we have all been facing in the last year and a half. And there is certainly a lot that we have learned through this time, which needs to keep getting updated. And in that whole process, we have planned this webinar this evening for the next hour and a half or so, where initially I will give a little bit of an introduction, first of our panelists, then of the topic, after which we will begin a panel discussion and end it with your questions from all our attending doctors who have joined us this evening. So our first panelist, Dr. Girish Soni, he's an associate professor with the Sir J.J. Group of Hospitals, GGMC Mumbai, a consultant neurologist with Leelavati and Wokhard Hospitals, and author of 3 books in neurology field, more than 20 national international publications. He's received the Best Assistant Professor Award at JJ Hospital and GGMC Mumbai, a member of IANCON Man, and also a Young Faculty National Awardee in the field of neurology in 2012. So a very warm welcome to Dr. Girish Soni. I think he'll be joining us very shortly. Dr. Kapil Rathi is joining me on this webinar again. We have done several before. He's a chest physician and an infectious disease specialist, a very unique combination. And his insights and practical tips and guidance from all the COVID related cases and care that he has done has been immensely beneficial to all our audiences, and I am sure it will be today too. So, a very warm welcome to Dr. Rathi for joining us. And finally, we have with us Dr. Swapnil Kulkarni, an intensivist and a pulmonologist from Pune. He's been a specialty medical officer in pulmonary medicine at ESIC Hospital, Mumbai from September 2014 to 15 September 2015. He's a clinical assistant in pulmonary medicine with Dr. Sujit Rajan and Dr. Pratibha Singhal between September 2015 and October 2016. He's an ex-consultant chest physician with GTP Hospital, Suri, Mumbai. He's now a consultant pulmonologist with KM Hospital, Pune, a consultant pulmonologist with Joshi Multi-Speciality Hospital, Pune, Ratna Memorial Hospital, Pune, Lokmanya Hospital, Pune, and also the director of the Nirmai Clinic, Apte Road, Deccan, Pune. So a very warm welcome to Dr. Swapnil Kulkarni also for joining us today on this panel discussion. We are talking about coronaviruses this evening, which really are an old foe in a new garb. The old foes, the HKU1, NL63, 229E, OC43, were simple common cold viruses, which still circulate in our community and especially in cold weather or certain seasons, cause a common cold with fever and a few other symptoms. And often the protection that people have from these infections wanes in a year or two, so they again catch the infection later. SARS-CoV, which came to us in 2002-2003, was the first encounter with severe acute respiratory syndrome due to a coronavirus. And then MERS, which came to us in 2011-12, gave us an even more severe version. And finally, in 2019, the novel coronavirus, which we are now dealing with, reared its head somewhere in November of 2019, and by December got reported by late Jan was already called a pandemic or was becoming one, and has since caused many issues. And very clearly, the SARS-CoV-2 virus is significantly different than the SARS virus, being almost 25 times bigger, much more infectious, much more contagious. R0 of the Delta variant is almost 5, which means one person can infect 5 people on an average. It has pre-symptomatic and asymptomatic transmission, which was not seen in the previous coronaviruses. And as we mentioned, there have been 4 variants, alpha, beta, gamma, delta, with delta being the latest, what you could call storm going around the world, having crossed 100 countries. And even in places where vaccination has been done, the delta variant is showing that it can infect people and even cause severe disease in some of them. The entry via the angiotensin converting enzyme 2 receptors is a well-known pathway besides others known for SARS-CoV-2 to enter human cells. And while we recognize they are largely present in the respiratory tract, alveolar cells in the lung, they are also present in the esophagus, the upper and stratified epithelial cells, all the way to the ileum colon, in the cholangiocytes, the myocardial cells, which is where it causes all the heart-related complications, the kidney tubules, bladder uroepithelial cells, supporting cells in the olfactory bulb, which is where it causes a lot of its respiratory or loss of smell symptoms, certainly very obviously represented in the brain tissues themselves, where it causes encephalitis, meningitis, and several other issues. And then through the neuropilin-1 receptors also gains access into the neurological system. The global count currently stands at about 19 crore cases with about 4 crore deaths around, around 40 lakh deaths around the world. We have clearly had about 3.6 billion vaccine doses given around the world. India is leading that with about 41.1 crore vaccines administered, though we still have vaccinated only about 6.5% of our Indian population completely, which is both doses. One dose about 20 odd percent. And combine that with the deaths that we have had, which clearly we all recognize may be underestimated, we are still only at about 25 to 30% of the population being protected, and we are far from the herd immunity count, which would be closer to 75 or 80% of the population either having had a natural exposure to the infection or got vaccinated. So we clearly have a long way to go, and still the battle is very much on. The primary symptoms, as we recognize, of COVID-19, the most common ones are loss of taste, smell, nasal congestion, fever, cough progressing to shortness of breath, but certainly muscle aches, fatigue, body, fever, chills, headaches, nausea, vomiting, diarrhea, symptoms appearing 2 to 14 days after exposure with an average of 4 to 5 days. And certainly there are a lot of other manifestations, including ocular, cardiovascular, neurologic, psychiatric, cutaneous, GI, amongst others. And we all know that up to 40% patients may even be asymptomatic and still be able to transmit the disease, which makes this such a challenge in terms of a medical scenario. When we look at the COVID-19 therapies and the prediction to provide benefit at different stages, we realize in early infection, there may be mild constitutional symptoms, fever, dry cough, and lymphopenia happens to be one of the key features. But we realize that elevated LDH, elevated ferritin levels, and certain other key markers can help us also as biomarkers know what's going on. In stage 2, we start seeing the abnormal chest imaging, transaminitis, low normal procalcitonin. The time course again is in the second week of the illness onwards. There may be a phase 2A and 2B. And subsequently, we go into the stage 3 of hyperinflammation, which is where most of the damage occurs and complications occur. And from there on, we get into the post-COVID complications, which we shall also be talking about today. Some of the therapies are listed here, but clearly these are, again, there are other options. We have monoclonal antibody cocktails available now. We also have the ability to recognize the disease and treat it earlier, at least preventively where possible, and intervene in terms of the progression of this disease through the different stages. We know that long-term sequelae from COVID-19 were known in the past also, especially patients recovering from SARS-CoV and MERS-CoV had impaired diffusing capacity for carbon monoxide, exercise capacity reduction in the first 6 months following discharge, and also seeing things like post-traumatic stress disorder, depression, anxiety. There were many other issues that were known, and these gave us an idea of what we would be facing. And clearly, a lot of people around the world now face these complications after recovering from moderate to severe COVID-19. And very rarely, or not uncommonly, even after mild, sometimes they may have problems. The diffuse alveolar damage that is seen in the pulmonary sequelae of COVID-19 occurs, one, due to the platelet fibrin thrombi and the coagulopathy that occurs with it, the damage that occurs to the blood circulation and blood vessels, and the hemophagocytosis and immune cell depletion. Combine that with all the cytokine storms and the inflammation and the hyperinflammation, and you realize that there can be damage which can sometimes become long-lasting or permanent. A very interesting case where a 57-year-old female with dry cough, no comorbidities, in the post-COVID phase, early post-COVID phase, or in the hospital requiring oxygen, no honeycombing, architectural distortion, mild restriction, reduced DLCO, post-walk desaturation of 5% within a distance of 220 meters. So clearly showing damage to the lungs in the acute phase in the 4 weeks since onset of illness. But subsequently, a month later, without any antifibrotic therapy, the patient is showing improvement in their HRCT. So we recognize that a lot of patients do resolve naturally, and it is very important for us to recognize which patients may need support or help and which patients require therapy. And I think that that is what will be the focus of our discussion. The extrapulmonary manifestations I've already mentioned. The one of focus today will be the neurologic. So we have headaches, dizziness, encephalopathy. Later on, things like the Guillain-Barré syndrome, loss of smell, myalgia, anosmia, loss of taste, strokes. I've already mentioned encephalitis, meningitis, quite a lot of different things that we see that can occur. And then we have the long COVID manifestations, where again, from neurologic brain fog, loss of sense and taste and smell that lasts for longer, to dyspnea, cough, chest pain, rashes, urticaria, psychiatric issues, cardiovascular issues, and then certainly peripheral neuropathy and other limb ischemia issues. So clearly a disease that not just affects the human being, but also affects them after the virus has left the body or has been fought off by the body, and leaves several sequelae, which we really have to do our best to avoid or treat. We won't get too much into the neurologic sequelae. We're going to discuss these. But even things like Parkinson's, dementia, depression, PTSD, anxiety are significant neurologic and psychiatric sequelae after COVID-19 that a lot of our colleagues from the psychiatry, psychology sections are seeing lately. Before we get into the discussion, just a reminder to all our doctor friends, remember that we need to take care of ourselves. Fresh air, sunlight, there's no better immune booster than that. Take it from an immunologist. A healthy diet, exercise, getting restful sleep may not always be possible for some of us, but where possible and when possible, yoga, pranayam are some of the oldest and most amazing things, along with meditation, make a huge difference for your immune system. Supplements have their challenges and questions, but certainly optimizing them but not using them incessantly can be valuable, and then a positive attitude and a mindset. So with that, I shall get into the first case, where we again talk about a 57-year-old male who post-COVID had no comorbidities, complaints of breathlessness, dry cough, gastritis, oxygen levels that were 94% but needing oxygen. This is now almost post-discharge. Blood pressure that's borderline. On a CT angiogram had dilatation of the pulmonary artery, pericardial effusion, which was mild. Fibrosis with traction bronchiectasis already seen. Severe pulmonary hypertension already developed. Severe restriction and reduction in diffusion capacity. Post-walk DSATs of 9% with 260 meters. These are some of the changes that were seen on the lungs. Clearly showing pulmonary fibrosis and traction bronchiectasis, and after starting antifibrotics, there is still fibrosis and traction bronchiectasis with honeycombing, but there is some improvement that is seen. So this is a case of post-COVID fibrosis, very florid with pulmonary hypertension. This is some of the medications that were required. So with this case as a launch pad, I would like to come to our panelists and begin our panel discussion. So Dr. Rathi, I would like to bring the first question to you. And the question to you is not necessarily related to the case, but my question to you is, do you feel, because there has been a lot of discussion about this, that between the first wave of COVID-19 and the second wave of COVID-19, people felt that suddenly the disease became worse? So in your opinion, because we did a lot of webinars together in the first wave, and this is one of the first ones we are doing in the second wave. So do you think that something changed in the virus? Do you think the manifestation changed? Do you think it was just the volume of cases that we were seeing, because of which we saw as much of problem and as much of need with all the resources falling short? So your thoughts on this. Was this a really significantly different variant, the Delta variant that we felt drove the second wave? So your thoughts on the presentation of this disease?
Yeah. Thank you, Etru, for that kind invitation, and thank you, Shithesh, for meeting up once again and putting up that really important question: what has gone wrong or what has changed in that span of 6 months or 8 months? So actually, if I can assess, or if I can actually see whatever cases I've seen, say practically close to 2,000 in this wave. So what we have seen, it has gone drastically change in the sense, symptom wise there was not much of change, but yes, as in severity wise, or as in virulent wise, it was quite change. So the rapidity with which the virus was getting to the people, and people getting sicker, and sicker in the sense, sicker means they are, to start with, they are okay, and say within span of 48 hours they are getting bad. That was the one very typical feature for the second wave. Two, there was more of a young crowd which was affected for the second wave. So that was again marking feature. Probably younger people hold on for a longer period of time with the respiratory and other efforts. So probably once they present to you, they present in a much sicker as compared to a patient with a COPD, asthma, or an old age patient. So that was again different. So whatever young patient presented to us in the hospital as an IPD were much sicker as compared to, say, first wave. Two, it was more infectious. So the time around, the turnaround time was quite fast as compared to deterioration part is concerned. And three, obviously, because there were a lot of infectivity and a lot of transmissibility. So we were getting bulk of the patients. Say whole of the family was coming positive and they were getting admitted. So we're running out of the resources. So practically most of the patient whom ideally has to be in the hospital were in the home because of non-availability and other stuff like that. So that way also we were actually getting little bad picture. So all in all, this was the first impression of the second wave, what we have seen. Symptom wise, little bit of different, but infectivity wise, virulent wise, transmissibility wise, and the volume wise, it was huge, humongous.
Absolutely. So I think we all agree that this was, some of the things that you mentioned, the age groups that were affected, the speed with which it was affecting, the cluster spreading that was seen in families was really why in the first wave we got up to about 90 some thousand cases a day, and here we went up to almost 4.2 lakh cases a day. So I think that it's important for our audiences to realize that this virus did mutate and change itself. There were 17 mutations between the alpha variant and the delta variant of COVID-19, or the D614G, and then the two mutations, key mutations in the delta variant. There were about 17 other mutations. So the virus really, it's almost like it went back to its blocks and changed itself and came back with much more aggression. So we have to really take this seriously and recognize that it could do this again, and hopefully it won't, and we'll have enough people protected by then. The next question that I would have is for Dr. Swapnil. Dr. Swapnil, amongst these cases that came in droves to the hospital, as Dr. Rathi mentioned, are there certain red flags or risk factors? Because you as a pulmonologist and then also as an intensivist probably have seen these cases progress. So are there certain biomarkers, certain features, certain, things that our audiences can look for to know which of these patients have the potential to get worse, and also who may, do better with more intensive or more aggressive approach for management so that they don't get worse? So your thoughts on that, Dr. Swapnil?
Yes, thank you, Dr. Shithesh, and thank you, Team Hetero, for organizing this webinar. If you ask me about the red flag signs, I would divide it into clinical and then laboratory wise. So clinically, if you see, so clinically most important parameter is breathlessness and hypoxemia. So those patients who are extremely breathless to begin with, or they develop breathlessness very early in the disease, are likely to get progressed. Those who have hypoxemia, which gets corrected with simple oxygen supplementation, but their tachypnea persists, their use of accessory muscles persists. So such patients, they are likely to get complicated and to develop severe COVID illness. And in the second wave, I have observed, most of us must have observed, that persistent fever is something which was not there in the first wave. So persistent fever, I have seen many patients who are stable respiratory wise, stable from oxygen saturation point of view and other parameters. But persistent fever is the one thing, and those patients, they got deteriorated later, especially in the second week, and they landed into the cytokine storm. So this is the one feature I would say this is the new feature, a new symptom or new sign which we saw in the second wave. And other parameters, biomarkers, if you say, then simple, the routine biomarkers, that is CRP is the most important one, which fairly correlates with the severity of the disease. Single value is obviously not important, but the trend, how it is, whether it is increasing or decreasing. If it is increasing, then how fast it is increasing. So it fairly correlates with the severity of the disease, and we can predict the future complications of the severity. D-dimer, yes, we know the thrombotic complications are very common. So D-dimer value is of help. Again, single value is not of help. We need to see it serially. IL-6, I would say in first wave, we have done IL-6 for many patients, each and every patient who require ICU. But there are many technicalities in IL-6. If you send the sample gets processed late, then there is a false elevation of IL-6 values. Then its cost is also an issue. Availability is also an issue. It is not readily available, and the turnaround time is also more than that of CRP. So practically we have stopped using IL-6 because you have seen IL-6 levels also fairly correlates. CRP also simultaneously rises with IL-6. So not doing IL-6 commonly. Other parameters, that is lymphopenia or NLR, that ratio also fairly correlates with the severity of the disease.
Great. I think that's very good insights, and I agree that in the second wave we saw a lot more people having fever for 8, 10, 11 days, and some of them turned around, and some of them, like you said, did get worse. And just goes to show, as an immunologist, when we see this happening, we know that the virus is continuing to multiply, continue to get released, continue to stimulate the immune system in a very aggressive way. And clearly, when that crosses a threshold, you get into the hyperinflammation syndromes. So, like we discussed, the virus did change itself and come back, with some new features. So, the next question I have is for Dr. Soni. I know he's been very silent and patient while we come to him. Dr. Soni, are you there? Yes.
Yeah.
So, Dr. Soni, while we are talking about these cases that come to us in the hospital, let's say in the moderate phase, are there certain neurological features or symptoms and presentations that our audiences need to look out for? Some of the things that may be seen in a moderate patient going into a severe, and what kind of neurological involvement is seen with COVID-19 in your experience of managing these cases?
Yeah. The number one, in mild cases, anosmia, other cranial neuropathy is common, like Bell's palsy, sixth nerve palsy, isolated mononeuropathy affecting the upper limb or lower limb. Common. From moderate to severe, what are the parameters? Number one is consciousness. If the patient is becoming drowsier to stuporous or going into the altered sensorium, that indirectly indicates that brain is also affected by COVID. Either it's a COVID encephalopathy or COVID encephalitis. If the MRI brain is abnormal, if the CSF is abnormal, or CSF shows COVID antigens or antibodies, that is a COVID encephalitis. Much worse prognosis. Most of the patient will be lost because of COVID encephalitis. Encephalopathy, yes, they do recover. And then the common presentation in ICU patients. Normally, the common presentations are COVID encephalopathy followed by COVID encephalitis followed by vascular events in the form of stroke, either thrombotic events or hemorrhagic events. Thrombotic events are common. Arterial affection is common than venous affection. So multiple infarcts. Usually we saw posterior circulation strokes are common with COVID. I don't know why. What is the reason behind it? Posterior circulation more common than anterior circulation. Then cortical venous sinus thrombosis. So the role of antiplatelet, anticoagulants are important, and we are giving preventive therapy, particularly in those who have a D-dimer value more than 500. Some people take more than 1000 as a cutoff level, but always better to give them anticoagulants. And post discharge also we are giving newer oral anticoagulant for at least 6 months to 1 year. Some people say 6 weeks, some says 8 weeks, some says 3 months, but I think 6 months to 1 year is needed. We saw stroke 4 months later on after COVID also. Milder cases manage at home 4 months, 5 months down the line, thrombotic events or stroke events. Then COVID status epilepticus, COVID-induced status, seizures, not controlled by routine anti-epileptic drug. Usually these patients need high dose of steroid. Then COVID movement disorders, most common is myoclonus, asterixis, flaps, positive myoclonus, followed by Parkinson disease. Then affection of the nerves and muscle, either critical illness myoneuropathy or GBS. So these are the common complications in ICU setup in a moderate or severe patients.
Got it. So I think this tells us that you and your colleagues have been really busy through the COVID pandemic with a lot happening, and really it's been quite a challenge, I know, for all of us in one way or the other, managing these cases in some aspect or the other. Dr. Kapil, I will come back to you now and ask you, while we are talking about the evaluation of these patients, and before we get into the management and clearly related to the post-COVID complication of fibrosis, the HRCT chest clearly is a very important investigation. Your insights on the best time to do this, where people are going wrong in doing it, and how important it is in judging the, let's say, in hospital or acute management, and also the later on management of these patients. So your thoughts about the HRCT in relation to COVID-19.
Yeah, I think HRCT was the prime investigation, probably the standout investigation among the all what we have ordered for COVID-19, and possibly most sensitive also. You say after RT PCR. So CT, we have probably we were more wiser in the second wave as compared to first wave. First wave it was like everyone was on the bank to CT. But again, the legacy of that first wave has carried to the second wave. So a lot of people were doing the moment they suspect COVID or the moment they got an RT PCR or antigen positive, and they rush to the scan center and get it done, and then come back to you before you ordering that, whether they were with the reports. So that was a wrong. So technically, we also know, as in pathology or as in pathophysiology, day 4, day 5 is the right time to do. Probably 3 days after symptom is the right time, or where you can judge. Or if the patient is presenting you on day 1 with hypoxia or something like that, then you are justified in doing CT on the same day of you are seeing the patient. But if the patient is just getting symptomatic from a day 1 or 2, probably hold on for 3 to 4 days. Now, what we have seen, yes, bit early changes of CT scan in second wave as compared to first wave. That is for sure. We have seen that the changes which were on day 5, day 7 on first wave were probably on day 4, day 5 in this second wave. So what we have seen. But again, to contradict my statement, I've seen a lot of patients who were absolutely doing well. They have done CT scan on day 3, absolutely clean, and on day 8, day 9, they turn out to be GGOs and other things. So you have to be very specific, because it typically changes your mind, because you tend to discharge patient because non-availability of the bed and or other issues, and then patient comes late with the little breathlessness or the so-called fever, what my other co-panelists have discussed. So continuous fever for day 8, day 9. So that again suspect you give probably the disease activity has not gone down. Clinically was better, but now it's a late cytokine which is coming up. So doing a CT scan is very important, but when and how frequently you should do is really an art which we have to learn. But typically, if you want to do a scan, do on day 4 or day 5 of the symptoms, not on the day you see the patient technically, only if there are some red flags where you want to order. Probably if you want to repeat it, which most of us doesn't do unless and until there is a steep deterioration, or you want to discharge patient was in the hospital for 15-20 days, ICU, NIVs and all other stuff, and you want to really see antifibrotics on the board by deciding on the CT. Otherwise, you don't do that. But yes, day 4, day 5 should be the right time. Don't go and ask for an buffet of a scan. Just go and say, boss, mera scan kara lo, so that I'm sure. A lot of time you will get a false negativity also. That is very important, and later you burn your hand because patient turned out to be bad. So that is my take on how to do a scan and how to follow up with the scan.
In terms of just keeping up with the same line of thought, if there is a patient who has spent a significant amount of time in the hospital, has is getting discharged, any thoughts on what would be the right time to do the second CT scan if we had to? And are there certain features that make you want to order the second CT scan? Any thoughts on that?
So what we have done in our unit, or what we have practicing, is that any patient who has got not a stormy course, or he was absolutely to start with, his was bad disease, like score of 12, 13 and admitted, but then it was like a smooth event. Within 7-8 days, settle down, everything, PCR negative, whatever negative. Generally, we don't do scan in this patient. That was we were very clear in our mind. But yes, patient who have a very stormy course, going up and down, coming to ICU, going back, probably developing late fever, or probably desaturating. Then at the time of discharge, probably you want to see what exactly lies inside the lung, so that we can at least be sure whether we can start antifibrotics or any kind of, for that matter, lung protective drugs, so that it doesn't worsen in coming, say, another 4 to 6 weeks to come. So probably in that selected case of patient, we done a repeat scan at the time of discharge, just to assess the situation, so that, or probably patient who were discharge on probably a liter or a couple of liters of oxygen and home oxygen therapy. Probably this kind of patient we have ordered in some cases, just to be on a safer side, whether we want to start antifibrotic or any lung protective drugs.
Great. I think those are very valuable insights. Dr. Swapnil, I'll come to you now. If you have anything to add to what Dr. Rathi has said about the selection of patients when it comes to doing a repeat CT, because I'm sure being in the ICU setting and managing these cases as an intensivist, if there are some other features that you all used to consider when you decide that, okay, we need to assess this person for other issues, do share that. And the question I have for you is, in terms of the common complications that you all would see in the ICU setting with these patients, what were some of the issues that you all were seeing, and what was the approach to that you all would have in these cases? So, you know, it's like we know that the severe cases are going there. We know that certain issues they are facing with the cytokine storm, but your insights through the last several months of managing these cases on what kind of complications were being seen, which will help us better understand the post-COVID scenario of this whole disease.
Yes. For your first question regarding the CT, I completely agree with Dr. Kapil. So if patient is clinically improving, then I won't advise a repeat CT scan for him or her. If patient is not improving despite of adequate treatment, is going to long COVID, or if you are suspecting some another complication, then yes, definitely I would advise for a CT scan. For initial CT scan, I would add one more indication for the early CT scan for the diagnostic purpose, where there is a diagnostic dilemma, where RT PCRs are coming negative. We still have a high suspicion of COVID. Patient is having signs and symptoms of COVID, but RT PCR is negative. In that case, we can advise, or we advise in our institute, early CT scan. Otherwise, as Dr. Kapil said, absolutely, after 5 days of symptoms, if patient is deteriorating, we advise CT scan. And complications, coming to the complications we usually see in ICU. So there are many complications which we have gone through, or we have been managing for COVID. Thrombotic complications are common, which are causes of which are the cause for sudden demise or death of the patient. Thrombotic complications are very common. Second complication, I would say, from respiratory point of view, is ARDS. Patients are developing progressive respiratory failure, and then development of the ARDS. Lung fibrosis or sequelae of the ARDS, or further sequelae of the post-COVID status, lung fibrosis. Then pneumothorax or pneumomediastinum. This I have seen many in second wave as compared to the first wave. So pneumomediastinum is very commonly seen. Sepsis, bacterial and fungal sepsis, and multi-organ failure is another common complication which we are seeing. And to all this, to prevent and whatever, so early diagnosis is the key, I feel. So those patients who present late, those who come late to the hospital, those who seek medical attention later in second week, they have more tendency to develop these complications rather than those who come early in those who get early medical attention. Antivirals, absolutely, like remdesivir, if given early, we have seen they do benefit, even if trials are not showing any survival benefit, but the duration of hospital stay and other parameters, they are definitely, we are seeing improvement on that.
Great. I think you raised some very important points, and certainly having a negative RT PCR, and I certainly recently a patient of mine whose 40-year-old brother actually passed away had a very classic story like this, had fever for several days, 2 negative RT PCRs, 1 negative rapid antigen test, a CT scan that was done too early on day 2 of disease, completely normal, ended up getting diagnosed as having other febrile illnesses, treated for several days, kept getting fever, kept getting worse, ultimately got diagnosed with COVID, but by then it was too late and he just progressively got worse. And the situation where there were no beds, no ICU beds, and really they lost that person. I think this is a classic example of too early CT scan and negative RT PCRs and quickly deciding that this is not COVID, this is some other illness. Certainly things that every person who's hearing us and has heard through other platforms needs to be aware about this disease. Dr. Soni, I'll come to you again with the next question. And what I would like to ask you is, in terms of signs, symptoms, in terms of presentations of the neurologic issues, what are some of the things that people need to be, some of them are obvious, like you said, if they are having those problems, they are having those problems. But any particular red flags or signs of symptoms that would make someone think of the more ominous or bad complications? And also, you mentioned strokes. So the types of strokes that are being seen, and are they in any way different? I know you said the location of the stroke, more posterior circulation versus anterior, but anything different about the presentation of these things? And because we know that coagulopathy is clearly behind a lot of these issues, like you mentioned.
Yeah.
And we also realize that direct invasion of the brain tissue is also an issue. So your thoughts on these things?
See, as such, neurological markers for COVID, there are no as such neurological marker, because there is so much vast presentation of neurological symptoms in COVID, starting from brain, spinal cord, cranial nerves, everything is affected. Muscle, coverings of the brain like dura mater, everything get affected. So there is no specific marker. But yes, COVID and stroke, there are two types of stroke. Ischemic stroke. Let's take ischemic stroke first. Ischemic stroke, two types of stroke. Number one, COVID precipitation of underlying risk factor related stroke like diabetes, hypertension, elderly patient, known case of previous stroke, getting stroke because of diabetes or blood pressure. Usually these are the lacunar stroke, less than 2 centimeter, located in the deep part of the brain, related to this risk factor. And second is COVID itself induced thrombogenicity. So posterior circulation are commonly affected. Multiple stroke of variable size, at some places large, at it looks like cardioembolic stroke, multiple places of the brain. So affection of two territory, affection of three territory is common with COVID thrombogenicity. So in such situation, you need to use a good therapeutic dose of low molecular weight heparin or heparin, along with single antiplatelet, followed by single antiplatelet and newer anticoagulate. So the management of COVID thrombogenicity stroke is little different as compared to normal stroke, because in normal stroke, we use a double antiplatelet for few weeks to few months, followed by single antiplatelet. Unless until there is an underlying atrial fibrillation or solid cardioembolic stroke evidence, then only we go for anticoagulation. But in COVID-induced stroke, we go for anticoagulation at least 1 year. And then then the venous infarct. Venous hemorrhagic infarct in COVID people, they are pretty large. The tendency for hemorrhages inside the brain is high. The chances of hemorrhagic infarct development is high, and they are large. Often they require craniotomy, emergency craniotomy. And then hemorrhages, including subarachnoid hemorrhage, intraparenchymal hemorrhages, we are seeing either because of COVID itself or maybe excessive use of the anticoagulant. We are not sure whether drug or whether COVID itself.
I think you raise a very important point, because the thing that we had not mentioned so far, but the high risk patients, the ones who have diabetes, ones who have hypertension, ones who have had previous strokes, ones who have obesity that is very significant or morbid, many of these underlying what you can cause systemic inflammatory metabolic syndromes, that when you add on a virus that does all of these things by itself, becomes a pretty bad mix. And clearly in the first wave, with all the elderly individuals or those above 50, 55 that were getting affected, we were seeing a lot more. But now in the second wave, we have seen this happening even with younger people. And young people getting strokes, as you said, hemorrhages, all of these things, and sometimes even after discharge from the hospital, like you rightly said. So I think that you bring up a very important point, and we'll come back to the discussion of which anticoagulants, when to be given, and those things. But for now, I would like to go back to Dr. Rathi and ask Dr. Rathi a question. Dr. Rathi, in your experience, when we talk about the post-COVID lung fibrosis, we've spoken about the HRCT, we've spoken about when to repeat it. Now we're talking about the actual people who develop post-COVID fibrosis. Um, Again, any risk factors that come to mind, any chance that what we are seeing now in post-COVID fibrosis, is it really preventable, or can it be intervened in terms of treatment? So your thoughts on that, and your approach to that. I think you've briefly mentioned that you do think about antifibrotics even when the patient is getting discharged if there are certain features. So a little bit more clarity on that, and what kind of antifibrotics do you like to select or choose?
Yeah. So I think what we need to understand. So we have to, if say the patient is on a moderate to severe COVID, having a long course in the ICU or hospital, or has stayed for more than 10 to 15 days, having long-term oxygen, NIVs, immunomodulators, steroid for a longer period of time. So this was one of the factors. Second, if patient is already an underlying diabetic, hypertensive, or a, chronic bronchitis, asthmatic, or any kind of the red flags if the patients are there. So these are the typically the category of the patient where we will be very alert and will be very careful in while discharging the patient whether he has got some feature of fibrosis or not. Secondly, as my co-panelists have told, whose patient who are hypoxemic, on discharge also, once their 6-minute walk test still remains on that borderline, still they are on room error 92, 93. Probably this kind of patient we need to be very careful. So these are all the patients whom we will be very careful for actually working up, probably doing a repeat CT before discharge. And if you see typically honeycombing or traction bronchiectasis or something like that, probably I will initiate antifibrotic at that point of time only, because I don't want too late, because probably this patient will come for 10 to 15 days. Sometimes this patient, a lot of this patient, if they feel better, they lost to follow up sometimes. So it happens. So sometimes it is a good idea to actually start in a given patient, not in all patients, but in a given subset of patient, antifibrotic at the point of discharge only. So that will be my strategy for antibiotic. But to be very honest, what we have seen in our series, it is not more than 15 to 20% of the patient who will require antifibrotic for that matter, for at the time of discharge or any point of time in COVID, post-COVID, illness. So probably it is there, but most of them, what we have seen, they actually get reversed within 3 to 6 months. So that is the good part. Whether they are doing not in O or probably our antifibrotics are working, that is still a little balanced question. But yes, to be very honest, I'll be very honest with myself, and I'll put my heart, hand on my heart and say I have been using, probably sometimes overusing antifibrotic, because we don't want to take any chances in these patients who are really on that edge where you are still not sure whether to give it or not give. Better to give it and see for at least 3 months and then decide whether to stop it or not. So that is the cautious approach what most of us will take in a given subset of patient. But again, I'll repeat myself, not more than 15 to 20% of patient will require antifibrotic typically for fibrosis.
I think that's very good insights, and I think that number matches with a lot of other people I have spoken with also, and I think it makes a lot of sense. In terms of choice of antifibrotics, Dr. Rathi, anything where do you think? I know it's the choice between pirfenidone and between nintedanib. So do you feel that one is better than the other? I know that this is active area of research going on around the world on this thing. I've heard people on both sides of the fence saying that one is better, the other is not, and many who say that both seem to work. So your thoughts on that, personal experience and personal, choice, and how you think if there should be certain things which make you choose one over the other, if at all, or what you think is first line and what you think is second line, whichever way you want to take the question.
Yeah, so I think first wave it was all pirfenidone. Second wave probably it is all nintedanib. Maybe because we are in India, so we have to think about cost effective and availability and everything also. So once this nintedanib was off patent and it was bring up to the very that cost which was mostly affordable. So there is an ease of administration for sure. So twice a day, simple dosing, either 100 or 150 milligram BD. Now I think nintedanib has little edge over pirfenidone in the sense it's a tyrokinase, tyrene kinase inhibitor and very specific to, the PDGFR and VEGFR and other stuff. So probably looks more logical. Trials also have shown that if you see impulses 1, 2 and other trials also, plus head to head also pirfenidone, it has done a shade better than pirfenidone as far as it is. So I think with all the background and probably a much safer, I'm not saying that pirfenidone is a bad drug, but the dosing is quite little tedious. So a lot of people don't understand how to dose it, at least non-pulmonary guys, because so it becomes really difficult for them how to increase, because the dose can go up to 2400 milligrams. But nintedanib is very simple. So either you give 150 or 100, it doesn't matter much, but at least you are on board with full dose, the main required dose. So that is good advantage. Twice a day, affordable, very practically, not that pirfenidone has got little liver issues where you have to monitor it very well. Little bleeding issues, it can happen, and we all know prothrombotic phase of COVID-19. So all in all, nintedanib becomes a much better choice as far as ease of the administration and to monitor this patient very well for a longer period of time.
Great, thank you very much. I think that's very helpful for our audiences. We are getting questions related to that also. Next question, I'm going to come back to Dr. Swapnil again. Dr. Swapnil, in terms of the complications that we have been discussing, especially for patients who are having severe COVID-19, with the severe COVID-19 scenario as it evolves, we have all realized that anticoagulant therapy is very important. So amongst the anticoagulant therapy, what has been your approach in the ICU for managing these cases for different types of manifestations that they may have that are related to the prothrombotic coagulopathic situation stage that they are in? So your thoughts about the anticoagulant therapy, its relevance, its approach, some insights for our audiences on that.
Yes. So anticoagulation is second therapy apart from steroids, which are proven to have survival benefit. In ICU or anywhere, I feel the heparin is the drug of choice. Either it could be low molecular weight heparin or simple regular heparin. There was to whom it should be given. It's a very gray area. There are different guidelines mention different things. Somehow, some guidelines mention cutoff of 1,000 for D-dimer to start anticoagulation. Some says even radiological opacities are indication for starting anticoagulation in high-risk patients. There is an interesting study from Mount Sinai where they perform autopsies on 26 patients, and they found that out of 26, if I'm not wrong, 11 out of 26 patients, they had multiple clots in lungs, brain, and heart, where they never thought of that. They never considered that these patients will have clots in their body. So that's why the anticoagulation, I feel, wherever we are getting in an hospitalized patient, wherever we are getting radiological opacities and there is high risk like associated comorbidities, we should start anticoagulation. For hospitalized patient, my choice would be low molecular weight heparin if there is no renal contraindication to it.
Do you use any of the other agents, whether they be oral or injectable, once a day? Are any of those, or you think that low molecule? Because I know many people have said that that is the drug of choice, very easy to monitor. You can follow the PT, PTT, INR, all those things, and adjust the therapy. But do you think that the newer anticoagulants also have a role in this, or do you think that they are more relevant for time of discharge?
I think they have more role at the time of discharge or the home management of the patients after giving heparin, because there is no literature available for their efficacy as such. There's no good data available to support the use of direct oral anticoagulants. So I feel at the time of discharge, depending on the risk of the patient, that is also again is a gray area, whether to give anticoagulation at the time of discharge if other parameters are normal. But if you have to give, then you can shift to oral anticoagulants. But I have never used those in hospitalized patients or those patients who require ICU care.
Completely agree. I think there you need something that's more manageable, where you can adjust the dosage and do what you need to in a more relevant way, because with the newer ones, you don't have any specific parameters to monitor really. So I think it makes sense what you're saying. Dr. Soni, you had earlier mentioned about the use of anticoagulants and, the single platelet agent, double platelet agent, then going to the, so what is the approach in the neurological cases? I know you've mentioned it briefly, but between agents like apixaban, rivaroxaban, do you have any preferences of what y'all are
Yeah,
using or what
most
y'all
of
are?
the many of the COVID patients, specifically elderly people or those who have a moderate to severe COVID, they also have an affection of the renal system, acute kidney injury because of COVID. So once their creatinine get affected, we have to give fragmin followed by oral anticoagulation if you want to choose. Particularly, we look at the D-dimer status and underlying associated other comorbidities like hypertension, diabetes, underlying heart disease, or evidence of some atherosclerotic vascular disease by doing carotid Doppler or CT angio. If any of these risk factors are there, then we prefer anticoagulant over antiplatelet. Amongst anticoagulant, most of us what we are using is either apixaban or rivaroxaban. We prefer rivaroxaban because once a day, kidney even if kidney function test is affected, we can use the rivaroxaban. Particularly dabigatran and apiximab dosing, you have to reduce if there is a renal impairment. With rivaroxaban, it is not there. Cost-wise also, it is cheaper as compared to apixaban and once a daily dosing. And again, dosing wise, rivaroxaban, some people prefer 2.5 milligram, 5 milligram, 10 milligram, 20 milligram. If the age of the patient is less than 70 or 75 years, then we prefer 15 milligram per day. If the age of the patient is more than 75, we prefer 10 milligram. If renal impairment is there, liver impairment is there, if the chances of bleeding is high, we actually do the has bleed score system. If on the basis of actually has bleed we use whenever we want to give anticoagulation in a atrial fibrillation patient. So we are using this scoring system here also. If the chances of bleed is high, then we prefer 2.5 or 5 milligram of rivaroxaban. If we want to use apiximab, standard dose is 5 milligram BD. But particularly in elderly patient, we give 2.5 milligram BD also.
Got it. That's very helpful. Dr. Rathi, in your experience on these same lines, any particular choices when it comes to the anticoagulants when these patients are getting discharged or during follow-up? Because we recognize that coagulopathic complications are there for all of us to deal with. So your approach, your choices, your thoughts on this whole thing.
So I think we have to look for, very importantly, I always go for what is practically available and everything. Both apixaban and rivaroxaban are both, direct factor 10A inhibitors. So they both are in the same direction. So there is nothing to choose between them. But there are certain advantage of rivaroxaban, typically once a day, have studied more. So the data is more prominent with rivaroxaban. That is what is said. Plus, it is cost effective because it has been off patent. So there are a lot of brands available. So probably in the interior also, you will get all these molecules very easily. So that is very important. So it should not be that you have written apixaban and patient doesn't get it and then, you stop it, because that is what is happening. So a lot of people take it for 10 days till the time they, they have their stock with them from the hospital. And once they go back to their place, they actually stop it. And they probably go to either, aspirin or something like that, which is not the case. So you have to give drug which is available, affordable, once a day, very compliant. So looking at all these parameters and obviously cost effective, probably rivaroxaban, stand out a little much better as compared to other drugs. I know apixaban has got the greatest data for COVID-19 because it has been more studied for COVID-19. Plus, it is more renal friendly because you don't have to adjust dose. So most of the patients have practically normal parameters at the time of discharge. So rivaroxaban once a day, 10 milligram to 15 milligram, I think that suffices all our, the pre-requirement to prevent that thrombosis. So that is my choice as of now.
Great. I think that's very helpful. I think we are almost coming to the last half an hour now, so I think we should move to taking some of the questions that have come in from our audiences. So I'm going to just very quickly look into these, and the first question is a very interesting question because we haven't spoken about vaccination because that's not the focus of our chat or talk today, our webinar and panel discussion. But the first question that came in is your thoughts about COVID-19 vaccine and thrombosis. Okay, so anyone would like to take that? I know this is a tricky one, and yes, Girish has raised his hand. Please go ahead, Dr. Soni.
See, we are seeing cases of thrombotic events after vaccination, typically 2 days till 1 month. Typical venous affection is more than arterial affection. Now, we are seeing a lot of cases of cortical venous sinus thrombosis, portal vein thrombosis also after vaccination. And many of these patients, they are associated with thrombocytopenia. Of course, we need to see the previous platelet count. If the previous platelet count is 2 lakh, and now if you do the platelet count, if it is 1.5 lakh, then this is relative thrombocytopenia. You have to compare the two platelets count before vaccine and post vaccine. Many of the patients, they develop platelet count 20,000 also. So this is immune mediated thrombocytopenia leading to thrombosis. So in such situation, instead of using Clexane, you need to prefer the Fragmin. And IVIG or plasmapheresis will be a great treatment of choice in such situation. So any vaccination related thrombosis, always look for the platelet count. If the platelet count is low, if the previous platelet count is not available, then go for D-dimer level as well as platelet factor 4 antibodies level. If the D-dimer is high or platelet factor 4 antibody is positive, then this is immune-mediated thrombotic events. Arterial events also we are seeing, but we don't know whether the arterial event is because of vaccine or because of underlying other risk factors, comorbidities.
Completely agree. I think this is an area in evolution, and as we get more data, this will become clearer. Certainly, in terms of the incidence of these events, this is just for our audience. It is not very common, but it is also not uncommon. It is definitely happening. Yeah. And as we know, several countries stopped using Covishield because of this. Several reduced the use of some of the other adenoviral vector vaccines. Or the other vector vaccines, but clearly it is something that we have to watch out for. Patients have to be informed about. If there is any kind of severe headaches or other presentations, I've even had a lady who had a splanchnic venous involvement, followed by severe abdominal pain, blood in stools, had a very obvious patch when they scoped her. And it was purely due to a local venous thrombosis that occurred in that area. She recovered fortunately and did well, but had come to me as a vaccine reaction for evaluation after a month. So certainly these are things that are being seen. The next question I have is it a good idea to be doing lung function testing in COVID-19 patients? Either, I know that during the illness, the answer is no, you don't want them spreading stuff to others. But post-COVID, pulmonary function testing, okay? Either Dr. Rathi or Dr. Swapnil, if either of you all want to take that, relevance of that, importance of that, thoughts on that.
Yeah, definitely we would come to know about the baseline lung function. Baseline means post-COVID lung functions, and we can track those after giving a therapy. But considering this pandemic, we were not doing any lung function test in first wave. We opened up between first and second, and again we had to close our lung functions lab during second wave. I have done lung function test in few people, but I feel that there 6-minute walk test is fairly correlates with lung functioning. And if patient is not dropping saturation on exertion, then we can consider it as a fair patient is having fair lung functions. So they are can be done, but not absolutely essential. If you want to do, because post-COVID patient, usually the patient gets weakness, fatigue, and the lung function test is effort dependent. So you ought to have a low FVC. If you want to do it, then do DLCO, that is diffusion capacity for carbon monoxide of lung, which is not that effort dependent. So you can do that and to see whether there is any diffusion abnormality. But that we come to know on 6-minute walk test also. So they are not essential, can be done.
Got it. Dr. Rathi, any thoughts from your end on using pulmonary function testing in post-COVID situation and relevance to what we are discussing in terms of picking up something that we may not otherwise pick up? Dr. Swapnil clearly said, the 6-minute walk test tells us about their basic lung capacity in what we would call a practical way. So your thoughts?
I think he has summed up very well. I think probably what we are looking at is basically the interstitium or probably the alveolitis, which is affecting the lung. So probably 6-minute walk test, saturation will do most, or probably some imaging also will catch up. Now, for all the people who are COPD asthma, those who want to do a lung function test, probably post-COVID and everything, probably the guidelines, ICS guidelines says at least 6 weeks you have to wait post-COVID to get into that lung function test. That too subject to the surrounding conditions. So that is where you have to, if you want to do a so-called, a planned, elective lung function. But as far as emergency goes, I don't think lung function will play a big role in changing the treatment of the patient, rather than that 6-minute walk test or saturations, or probably an DLCO can suffice if you want to do that.
Completely agree. And I think in the acute phase, none of us would want it to be done also, because, it's a great way to spread the infection, no matter how much precautions you take. So I think it's mostly post. Yeah, Dr. Swapnil, please go ahead.
One additional thing we get from lung function is whether patient is having airway involvement and whether there is any reversibility post bronchodilator. For certain set of patients whom there is persistence of breathlessness or wheezing or cough, despite of adequate steroids or antifibrotics. In such patients, we may get a lung function test done to check for the post-bronchodilator reversibility. And such patients can be treated with inhaled corticosteroids and long-acting beta agonists. So for those patients only, we can get lung function test done. That is an additional information which we can get. But again, simple peak expiratory flow rate, which we can do easily in 1 minute at OPD procedure, that can replace lung function testing here again.
I think you bring up a very good point. I've certainly had my share of cases come to our clinical practice in Bandra where they have come to us with breathlessness post-COVID, and they clearly, it did not seem like they had a mild to moderate course, most of them that we have seen. And when we picked up, it was basically an unmasking of an underlying asthma that they already had before, or an underlying COPD that was in development. And the disease was one of the reasons that they became more aware about it, came to us and got diagnosed with what their real condition was. And many of them also were found to be allergic, which interestingly, we know that allergies and having that kind of inflammation in the airways is indirectly somewhat protective towards COVID. So maybe that's why they had a mild to moderate course and not a severe one. So I think that's a very important point, is to pick up the cases where they may have a comorbidity, let's say, with the COVID. There's a interesting question. Are there any markers of COVID fibrosis? I know the answer to that, but I still, it's from our audiences. I want you all to go ahead and take it. Are there any markers? I'm assuming when they say markers, they mean biomarkers for COVID fibrosis.
So if you ask me, Shithesh, but there are no biomarkers, unfortunately. So to disappoint my all audience, there are no biomarkers. It is all clinical or probably radiological, that the both of will come to know actually where your patient stand. But there is no standout test to say that it's the patient will have like TROP-T for myocardial infarction or something like that. So if you are thinking for that, there is no biomarker. It is purely clinical and radiological diagnosis.
I think that's an important message to give out there, that it is a clinical and radiological diagnosis, combined with obviously the person continuing to require oxygen or the other factors that we need, the walk test still being abnormal. We've already discussed all those things. So, but I agree. And in a research scenario, I know that TGF beta and a couple of other things are capable of being tested and looked at, but can't be done in routine practice. So, yeah, go ahead, Dr. Swapnil.
Well, yeah, but yes, absolutely. TJ beta and other, they are under investigation, and that they are not readily available also. Radiological, as Dr. Kapil said, radiological markers we can consider to predict the development of fibrosis. So literature, if you go through literature, then it says if more GGOs are there, then there are less chances of development of fibrosis. If GGOs are associated with consolidations, then there is slightly more chance as compared to GGO alone for development of fibrosis. And when there are pure consolidations, dense consolidations, then there is a highest chance of development of fibrosis. So these, we can term it as a radiological marker to predict development of fibrosis. And other is duration of symptoms. So if the duration of illness is less than 1 week, then we know there is 4 to 5% of the 4 to 5% chance of development of fibrosis. If it is more than, if it is around 1 to 3 weeks, then there is it's around 20 to 25% chance of development of fibrosis. And if it's more than 3 weeks, then there's definitely around 60% chance of development of fibrosis. So these parameters we can consider to predict the development of fibrosis in certain patients. There are other factors also like male sex, familial history of fibrosis, smoking history, underlying lung fibrotic conditions like interstitial lung diseases. Those patients are likely to have more and more fibrosis in post-COVID state.
I think those are very important points. So while there may not be any blood biomarkers, there are clearly what we would call red flags or high risk factors which can be followed and tracked and looked at for these cases in terms of duration of disease or the nature of the appearance on the radiology and those things. The next question that has come in, which I think Dr. Rathi kind of answered and also Dr. Soni have answered before, which is the duration of dosage of, actually Dr. Rathi, nintedanib, if you were to use the antifibrotic agent, how long do you use for? So I think you had mentioned about 3 months, and after in that time, obviously you're following up with the patient and seeing their progressive improvement, probably tracking their changes on their HRCT. So would you say that that's a reasonable timeline, about 3 months, maybe 6 months?
Yeah, I think 3 to 6 months is a good time to actually take a call whether to stop or whether to continue the drug. So probably if patient has to get better, it has to get better within 6 months. So that is what is our practical experience also. So probably, yeah, a lot of almost I should say 2 to 3% of our patients are practically on nintedanib for more than 6 months also. They are still going on because still they are not that, the recovery is still not satisfactory.
Complete. Yeah.
But most of them will, they will go in either direction in 6 months. So probably 3 to 6 months is the time where you have to take a call whether to stop or whether to continue.
The very next question is, what should be the minimum and maximum duration of nintedanib being used in such cases? I know this is a very, very tricky and subjective question, but still for the benefit of our audiences and our colleague doctors are asking. So
yeah, I think 12 weeks should be the minimum course. At least 3 months has to be there. Before that, you can't say whether the drug is active or not. That is for sure. Maximum time, it all depends on clinical response. The data is almost for 48 to 52 weeks, where you can use it. That is not a problem. But we all know COVID is an 18-month-old disease. So probably we are also learning how long to be used, and we are also learning from all our colleagues. But what we have realized, at least 3 months to maximum a year, that is what we are seeing as of now. And if you see data for SARS-CoV-1 also, which was there in 2003 and 4, maximum of this patient have recovered within 3 to 6 months. At least radiological and clinical clearance was there in 3 to 6 months. So extrapolating that also, typically probably 3 to 6 months is the time. So minimum 3 months, maximum probably a year, or maybe we don't know. So we still are waiting for the right time.
Sure. And I know that there is active clinical research going on this, and we will get better answers in the near future. And, there's a ton of publication that has happened since COVID began. And I think programs like this help us pool our knowledge together, because everybody can't read everything. So I think that that's very important. I would say that those who are viewing us, if our viewers have questions, do feel free to send it in to us. If we are not able to take it during the program, we will individually respond to you all after the program also, if need be. The next question is, can an anticoagulant and nintedanib be given together? Again, I know the answer, but I leave it up to you all to take it as panelists. Can these both be used together for whatever reason that the patient may need it? So
yeah, we have used it. We have been using it, but there is theoretical risk of bleeding while on nintedanib, since nintedanib is inhibitor of platelet derived growth factor also. So if you are giving anticoagulation with it, give it if it is absolutely necessary. If you are giving, then monitor properly. That's what I feel.
and I
And
think
if there is high risk of bleeding, then don't use nintedanib, use pirfenidone.
yes. And I think also probably using a lower dose, going with the 100 versus the 150, might make some difference and some protection. So
Yeah.
I think that answers that question. Um, the next question is again a tricky one. One of our doctors asks, what is more advisable, waiting for the fibrosis or starting the drug too early?
Obviously, starting drug early is the key, because these drugs have shown to prevent development of fibrosis. They're not shown to reverse the fibrosis. Whatever fibrosis is reversing, it's reversing on its own. So if you given early, the benefit is more. There are two types of fibrosis: pathological fibrosis and reparative fibrosis. I would say reparative fibrosis definitely will resolve on its own, or it will not cause much of a harm. What we see in post-TB cases most of the time. While in interstitial lung disease or IPF, it is a pathological fibrosis which progresses fast. So in such cases, antifibrotics have a role where early initiation would probably delays or slows down the progression of progression of the fibrosis. So earlier is the key, definitely.
Great. Let's see the next question. I think this again we have answered. The question is, how do you choose between the dosage for nintedanib, whether you go with 100 or 150? Any guidance on that or any suggestions on that?
Start with low dose, see whether patient is tolerating it or not. GI side effects are most common, that loose motions are most common, diarrhea is most common. If tolerating, I usually repeat LFT after 5 to 7 days of starting a low dose. If it's patient is tolerating, LFT is good, go to therapeutic dose, proper dose.
Sounds good. This question specifically comes for related to both IPD, ICU, and discharge patients. What is the dose of pirfenidone that needs to be started, and do you do it in the same way that you do it with ILD? And some guidance about the dosage for pirfenidone. Do you start with the lowest dose of 200 TID and then build it up from there? Do you build it up the same way that you build up with ILD or IPF? So guidance on that is what our audience seeks.
So if you ask me, I think it is, you have to start, you can't start. So probably 200 milligram TDS, that is where we start, or probably 800 milligram is something we start. And then gradually you build up, because, there are a lot of other drugs which are going on in this matter. So you have to be really assured what you're starting. And it is always a good idea, because you never know how this post-COVID patient are going to behave. So probably it's a safer and wiser way to start with a lower dose, probably 200 TDS or probably maybe 400 TDS, depending on, how safe you feel in that given patient, looking at the biochemical and other parameters. And then you gradually build up, say, within 2 to 3 weeks, so that you come to a full therapeutic dose, what you want to achieve. The same is for nintedanib, as my co-panelists have said, you start with a dose which is bare minimum, and then you see, because these are little toxic drugs, they doesn't come very easily, they sometimes they really change, or sometimes you have to monitor them very well, because this patient have been on, we don't because this will be, they will be on some people will be on long term steroid, or some people will be practically a lot of people uses a lot of antibiotic post COVID also. I've seen so many discharges with antibiotics and everything. So you have to be a little sure. So you have to monitor well. You have to build up the dose, and probably once you settle down your patient, when patient is on maybe a couple of drug only, then it is fair idea where you are going with your patient. So that is how we should go for at least post COVID fibrosis.
Anything you wish to add, Dr. Swapnil, to that? I think
that's perfect. Yeah, with these drugs come with adverse effect. So build up, monitor, and then build up the dose. But make sure you give a proper dose. I've seen many prescriptions of 200 OD or 200 BD of pirfenidone. Patients are taking that. So please avoid that, because in trials also for ILD, the dose is 30 to 40 milligram per kilogram they have used. So approximately for an average 60 kilogram person, it comes around 1800 to 2400 milligram per day. So use therapeutic dose, not underdosing should be avoided, I feel.
Would you say the build-up for the pirfenidone, like it is done, like, if 200 TID or TDS is tolerated, then after a week or 10 days, you go up to a higher dose? Do you think that a similar approach needs to be done here, or you think it needs to be more gradual?
Actually, I increase it slight rapidly as compared to ILD, because we have seen this COVID fibrosis progresses faster than that of ILD. So I have seen, I start usually 400 TID at start, and 99% of the patients are tolerating well. So that in next week we can step up to 1600 to 1800 at least. Monitoring it. So most of the patients are tolerating well. For that matter, even nintedanib also they are tolerating well.
Perfect, great. The next question, how and when to titrate in rivaroxaban between 10, 15 and 20 mg? I think most of us agreed that 10 to 15 is really the way to go. 20 in probably some selective high-risk cases with other comorbidities, but I think it's not a very big difference. Wouldn't you all agree between these three dosages? And as
10 to 15 preventive dose, yes. Therapeutic dose, yes, 20 can be given. If in proven pulmonary embolism or DVT, or we can give 20. But for prophylactic, yes, 10 to 15 should be the idea.
Okay. The next question is, can we shift a patient from pirfenidone to nintedanib, and will it affect the patient's health, or will it help improve the patient's condition compared to what pirfenidone was doing? So any thoughts on that?
Can I say?
Yeah, please.
No, just if patient is not tolerating one drug, then you can shift to another drug. There is no head-to-head comparison trial which has come out showing superiority of one drug over another. You need to see whether patient is tolerating well or not. If not tolerating, you can shift it to another drug. Pertaining to this and the previous question which was asked about the minimum duration, actually in one of my patient, as Dr. Kapil said, the minimum duration 3 months, we target minimum 3 months we have to give antifibrotics. I had started nintedanib, and after 3 weeks he started showing raised liver enzymes, so I had to stop that nintedanib. I was so since the liver enzymes were raised, I could not start pirfenidone also. So and for that patient, I had given it for 27 days maybe, and later patient also clinically improved, and there was no need to continue antifibrotic also. So some patients are developing, some patients are improving on their own. I don't think in this particular case antifibrotic had worked because it was so early. So the least duration was 27 days in my case, but yes, 3 months is the initial target which we keep.
I think that's an important thing, and I think this brings up a very important point that our audiences need to realize is there is polypharmacy going on in these cases. These patients have already, before coming into the hospital, taken a bunch of medicines sometimes. They've come into the hospital, taken a bunch of medications for the different reasons that we have already been discussing for the last hour and a half almost. And so drug-drug interactions, effect on the liver, effect on the gut. All of these are very important when we are initiating, following, and considering continuation or discontinuation of these drugs, with monitoring, as has been said, both clinical and lab parameters, which have been mentioned. So I think these are all important messages for our audiences. Yes, Dr. Swapnil, you wanted to say something? Okay. Next is an interesting question. Can remdesivir be useful in the third wave? It has been useful in the first and second wave, in my opinion. I think it's been overused. I don't think anyone can deny that. But I think the question is, will it be useful in the third wave? And so I know we know the answer, but for the benefit of the audiences, both of you all can take that.
Whatever is our act 2 or whatever data you select, there will be always two schools of thought. But if you believe the practical experience of all of us, if you put all of us together, practically close to more than 10-15,000 patients, we know by our heart this drug is working. So it is only timing of the drug where you have to be, you have to hit the nail. So that is very important. So yes, yeah, that is the key. There is no point in using it too late or using it too early on early phases. So probably right timing for right duration. A lot of people have gone overboard for 10 days or something like that, which I think in very rare cases, if drug has to be act, it has to act in 5 days. That is what I believe for remdesivir, and it does act in 5 days if it has to act. So probably yes, answer is to your question, Shithesh. It is going to be used. You don't have any other choices. I know cocktails and everything we have been using, but we all know there's a lot of escape phenomenon which is happening. Probably, the only RDRP inhibitor which is available as of now injectable is remdesivir, and probably we are much wiser how to use that and when to place that. So in that sense, it is going to work in also third.
Sounds good. I think we all agree on that. The last question that we have for today before we wind off, we are right on time. It's a very interesting question. I'm going to read it as it has come. I know what you all are going to think, but it says in home quarantine patients, okay, in home quarantine patients, are there red flags that indicate that we should be starting anticoagulants or antifibrotics? It's an interesting question, and I know that there are people who are using these drugs outpatient in a person who's never been hospitalized, who may have had a mildly abnormal or a moderately abnormal CT scan, but has no hypoxia, no need to get admitted, no issues otherwise. There might be people who have some comorbidities that are there. So I think our audience is suggesting that is there a role for the oral anticoagulants and the antifibrotics in home treated patients with COVID-19? I know this is a difficult one. Either of you all can take.
Yeah. So I think we are talking about 70% of the patients who are going to be at home, probably mild symptomatic or something like that. So out of that patient, there will be a chunk of patient who will be requiring not antifibrotic but antithrombotic for that matter in some cases. Now let me elaborate that. How we can choose that. So we have to again go for high risk patients. So probably old age patient, already known case of probably an underlying disease, a diabetic, hypertensive, or patient like obese patient, or patient for some or other reasons have to be in the hospital, but because of other issues or non-availability of bed has to be treated at home. Luckily come out and everything, but this kind of patient will require prophylaxis for a longer period of time, at least antithrombotic, because we all know probably antifibrotic, but antithrombotic will save the patient's life in coming at least 4 to 6 weeks. So my take will be probably antithrombotic in some subset of patients who have been treated at home with all the condition what I've listed. Antifibrotic, I'm not sure. Probably I need to see a scan and see this patient again and then decide. But probably antithrombotic, yes, in the home patients also, in home quarantine or home treated patient also. But with with that background in the mind and with all the condition what I've listed.
I completely agree, and it is something that we have used from time to time, as you have mentioned, and have to and recognize, because we know that there have been enough cases, and we have all heard about it through our not just through patients, but also through friends and family members and networks where people have gotten coagulopathic complications after a mild COVID within a span of 4 to 6 weeks. So with no other risk factors. So I know that this is something that in well-selected patients, the antithrombotic therapy certainly has a role. Dr. Swapnil, anything you would like to comment on what Dr. Rathi has said, or you?
No, absolutely. Antifibrotics, I don't think there is any role of antifibrotics in those patients who doesn't have hypoxemia. They doesn't require oxygen. They, at least 6-minute walk desaturation, they don't have. Then there is, I don't think there is any role of antifibrotic. Anticoagulation, yes. In certain patient, high-risk patient, we can consider giving anticoagulant. But then monitoring and the proper monitoring is the key.
Sounds good. I think we are at 9 o'clock and we are coming to the end of our panel discussion. I think it's been great. We've taken up some very important topics and points. I really want to thank the Hetero Healthcare entire team, Rishi, Mr. Sailesh, Mr. Shastri, and everyone else working behind the scenes for making this program possible. We really thank our audiences for being with us throughout the program, for asking very relevant and interesting questions and very practical questions. And I want to thank our panelists, Dr. Rathi, Dr. Kulkarni, and Dr. Soni, for really giving us very, very insightful and practical guidance and answers today. And really leading through a very tricky topic, as I may say, which is still, and all these areas in areas of evolution, which we will learn more about in the coming weeks, months, and years. But I think it's been wonderful having all of you all, and really thank you all for being a part of this webinar with us.
Yeah, thank you, Hetero, and thank you, my very close friend Shithesh, for moderating it so well as usual. You have done a wonderful job. Again, we should say that you bring up all the issues which are very pertinent and very practical. And we all know this platform actually speaks out, what can be done rather than what has to be done. So that is very important. So again, thank you, Shithesh, for moderating and again bringing out, that unanswered questions from all of us. Thank you.
Thank you. Thank you.
Yes,
thank
absolutely. Thank you so much, Dr. Shithesh, Team Hetero, Dr. Kapil, and Dr. Soni. And while we wind up, there is a good news. You must have seen ICMR has announced results of 4-0 survey. So it's showing 67.6% of the zero prevalence of COVID among 29,000 subjects which they have studied. That's
great.
good news. I feel 67.6% is very close to herd immunity.
Yes,
Hopefully.
yes, I think that's our biggest hope to prevent the third wave. So I think that's what we are all wishing and hoping for. So,
and out of those 29,000, whatever they have studied, only 13% were fully vaccinated. So that is another good thing. So hopefully
I think we can all close today's session on that optimistic view and that hopeful and positive view. And once again, Rishi, if you're there, over to you. Otherwise, we can call it an end for this webinar. Thank you very much. Everyone have a blessed night and take care, stay safe. Look after yourselves first, because if jaan hai to jahan hai. And take good care of yourselves, guys.
Thank you. Thank you so much. And you have a good night. Thank you so much, viewers, for watching us also. Thanks. Bye.
Thank you.